Saya Dr. Dimas sebagai MC dan atas nama panitia mengucapkan selamat datang di acara Plenary Session 2 Konas 19 Perhati-KL 2022 dengan tema Vertigo. Untuk memandu sesi ini, kami undang moderator Dr. Siti Faisa Abiratno, spesialis telinga hidung tenggorok bedah kepala leher, subspesialis neurootologi, Magister Science AudVestibular Medicine. Kepada Dr. Siti Faisa, dipersilakan untuk memulai acara.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, colleagues, and goedemorgen, Professor Kingma. I understand that this is now around 3 o'clock in the morning, right? Because yes, there is a 5 hours difference between Maastricht and Jakarta, and Bandung, sorry. It is my pleasure to be a moderator of today's plenary session on vestibular. However, due to pandemic situation, today's plenary will be done by hybrid presentation. On behalf of the 19th Otorhinolaryngological Conference Committee, I would like to extend a very warm welcome to all participants in this plenary session. This morning, we have 2 speakers, Professor Herman Kingma and Professor Jenny Bashiruddin. We are honored to have Professor Kingma, clinical vestibulogist from the Department of Balance Disorder, Maastricht University, who is going to share with us his insight and expert knowledge on the issues of vestibular dysfunction evaluation. As already had known that Professor Kingma has devoted his career to advocating the vestibular sciences and has contributed to numerous symposiums, teaching courses, workshops, seminars worldwide on the topic of vestibulology. Before we start, I just would like to practical information that you are all kindly requested to mute your laptop or computer to avoid any background noises that will distract you from listening to the lectures. Now I would like to invite Professor Kingma to share with us his lecture entitled ENT Role and Vertigo, Pathophysiological Diagnostic and Management Challenges. Professor Kingma, alstublieft.
Dank u wel. Thank you very much. I will share the presentation. Can you see it? I hope so. Yes. Okay, let's start right away, not to lose time. First of all, thank you very much for inviting me for this lecture. It's a pleasure and an honor to do so. Let's start right away. If we talk about vascular disorders, then it's about, of course, what are symptoms, what is the pathology, and what is the management. And of course, there are many different kinds of vascular disorders, and it will be impossible to deal with them all in 30 minutes. So I will pick out a number of important things that I want to share with you. New developments, new issues that came in our interest and under our attention. So I think first thing that you should realize is that the vestibular labyrinth is the most sensitive and fastest sensor of head motion and head tilt, combining the information from utriculus and sulcus to detect any motion, gravity, a head tilt, and the canals specifically detecting rotations. Now, together they help you to identify any motion of the head. They are the fastest and the most precise ones. They are much faster than the visual system and proprioception. So it means that if you lose vestibular function, automatically that means that you lose speed. So you feel generally that you become older. That's one of the things that people mention. Now, you use your labyrinths for many things. For example, for fine-tuning your circadian rhythm, it analyzes your movement and programs your biorhythm. It contributes to all kinds of autonomic processes, among which also the fast blood pressure regulation in your brain. But of course, like you all know, spatial orientation, navigation, balance control, image stabilization. And it does these things in combination with all other senses that are available, like the gravitoreceptors in your body, the foot sole pressure receptors, vision and hearing. But again said, the specific contribution of the balance system, the labyrinth, is speed. So without that, you can still walk and orient yourself, but everything goes much slower. So there are various types of vestibular disorders. Now you can roughly discriminate 4 different ones. So we have a dysfunction of the labyrinth, like in BPPV, benign paroxysmal positioning vertigo, like in superior canal descendens syndrome, the third window, or a fluctuating function like in Meniere disease, or a slow progressive loss, vestibular schwannoma, or aging. And then we have acute loss, neuritis, or neuritis vestibularis, acute vasculopathy, intoxication by gentamicin, things like that. And they all have a different management, of course. Now, the first thing is, like I said, the labyrinth. And one of the best examples of how things can go wrong is like with BPPV, that you have calcium carbonate crystals that come from the utriculus, they detach from the membrane into the canal, and they change the labyrinth, the canals, into a center of gravity. Only very recently, a year ago, Yamani and Konki and Anniko showed that it's possible to visualize the particles in the paroxysmal vertigo of BPPV. There are many, many ways that you can deal with BPPV. But important is to realize yourself that the liberation maneuvers, the Appli, the Semol, Appiani, Zuma, there are many. These are the first choice ways to deal with BPPV. And you do that, like you can see in this simulation, by moving the head in such a way that the debris moves through the canal, and then it ultimately should end up in the labyrinth in the utriculus. Okay, now this is the #1 choice. Are there other choices? Well, there has been suggested that vitamin D plays a role in the creation of otoconia in the canal, so debris. There's not a lot of hard evidence. There are pro and contra publications. Another suggestion is betahistine. Can it maybe play a role in this process because it controls blood circulation in the inner ear? Can it play a role in residual dizziness? And a very recent paper from Chinese researchers shows that it might reduce this effect of BPPV and the dizziness, so supporting liberation maneuver, especially in the difficult cases. Now, an acute peripheral syndrome is something that is very impressive for patients and doctors. And it can be unilateral and it can be bilateral. Often it is unilateral. And what happens is that you have this acute asymmetry between the two labyrinths, inducing severe vertigo, rotatory sensation, nystagmus, nausea, and imbalance. This is the typical syndrome. Only 40% of the patient will recover, and the rest will have a permanent loss. And it can happen again and again. So there is a chance upon recidives in a few years. Okay, what should you do in this acute unilateral peripheral loss? Well, #1 is, of course, to discriminate between central and peripheral. Now, if you want to know for sure that this is a peripheral lesion, then at least the head impulse test, a fast movement of the head, should be abnormal, should show that there is a problem. I don't have time to go into the head impulse test, but there are many papers published about that. But the treatment by itself, if you know that it is peripheral, is first of choice is, of course, rehab. And here you can see from an old paper from Subsp that when you do no rehab, there is only a slow and limited recovery, reduced sway. Whereas if you do a lot of rehab, you see a fast decay of the instability and a fast recovery of function. So rehab motion is number one. Now, the crucial thing here is that you have to start within 8 days, because we learned from many research that there is a critical period in which the brain is very sensitive for central compensation, and that's only in the first 8 days. So if you wait too long, then the effect of central compensation will be much less. So get the patient as soon as possible out of the bed. Now, within 1-2 days, and that enables the vestibular compensation, and you try to use then physiotherapy to get the patient moving and to improve central compensation. You can combine that with beta-stina, 48 milligrams per day for minimum for 3 months, because the central compensation process, roughly the most active part is in the first 3 months. Now, it's very difficult to get the patients out of bed. Of course, they feel very dizzy and nausea. So you can use antiemetics and, for example, cinnarizine, a vestibular sedative, for 1 or 2 days, not longer. So putting a patient for a long time on cinnarizine, for example, is a very bad habit, because it will reduce compensation and adaptation. So fast movement, beta-stina, and only for 1 or 2 days reduce the vertigo and the nausea. Now, Meniere disease is a quite complicated disease. We still do not have a clear view upon what is going on there in the labyrinth. But what we know is that there is a fluctuating function, vestibular function and auditory function. And in this first period, the tests are normal. And then in time, you see a very fast decay of vestibular function in combination with attacks. So then people have the attacks, but slowly the attacks become less and less and less, and they end up with a very bad labyrinth and with hearing loss and tinnitus. And these are permanent things. Now, we know about hearing loss and tinnitus, but not many people are aware of the fact that here we have a patient that doesn't have attacks, but has a sensory loss, which also has implications. Now, after each attack, it's better to start moving as much as possible, like with a neuritis, and add 48 milligrams beta-stina for 3 months after each attack to improve, optimize the function of the labyrinth after each attack. So that is the regime that we start to use. So always intensive counseling, optimize adherence to any therapy is important, and then start to use the 48 milligrams beta-stina. And then again, during the attacks, for 1 day or something like that, you can use a vestibular sedativum or an antiemeticum. Ultimately, you might face other problems, that there is a persistent problem, and then you can consider elimination of a reduction of the high drops. But that's only, in the severe cases. Okay, now imagine that you have acute bilateral vestibular loss. That seems to be more severe than a unilateral. Do you have vertigo, nystagmus, imbalance, and nausea? What is going on there? Now, there was a very brave 2 ENT doctors from Sweden, Mans Magnussen and Michael Karlberg, and they did the experiment on themselves. This is the victim. So he got small injections, transtympanic, of lidocaine, first on the right side by his colleague, Mans Magnussen from Lund University, and then on the left side, and then he was waiting what was going to happen. So he had an anesthesia of both labyrinths as an experiment. So after a while, he started to feel more and more nausea, and he felt no vertigo. So nausea, no rotatory sensation, and no nystagmus, as you will see in a moment. So the eyes are complete stable. And that is because there is no asymmetry, there is a symmetrical loss. If that happens acute, then you get the nausea. If it happens slowly, like in aging, you don't notice it at all. It slowly goes, like in a schwannoma, but then on 2 sides. So nausea, very severe, and severe imbalance. So he felt 10, 20 years older. He can still walk, but the nausea became stronger and stronger. So he ended up in the toilet vomiting for 45 minutes, and crawling over the floor, trying to reach the bed, and hoping and praying that everything would become normal again. Okay, heavily sweating, severe nausea, no nystagmus, no vertigo. And it took about 8 hours before there was full recovery. They did it 3 times. The second and the third time they used antiemetica, but they saw the same result. So you can lose vascular function completely without vertigo, without nystagmus, only with severe imbalance and oscillopsia, instability of the eyes, because you're having no vasovagal reflex anymore. And there are only neurovegetative symptoms, nausea, in case of the acute situation. So you can lose both labyrinth, a severe case, without the history of vertigo. So 65% of patients with an acquired bilateral vestibular loss have no history of vertigo at all. And therefore, even if balance is caused by a vascular deficit, it's often not recognized as such by GPs. And they don't send the patient to the ENT and to the neurologist, which is the reason why you don't see them. But what is the prevalence of bilateral vascular loss and aging? Well, look at, for example, the eyes. We have presbyopia. So about 70% of the people over 40, 50, they have presbyopia. Only the 20, 30% that have severe myopia do not suffer so much for that reason, because they can still see at a short distance. The same holds, for example, for cataract, very common. Now, what about aging of the vascular system? Well, we know from the statistics of the Netherlands that there is an increasing loss of hearing. As you all know, when you're over 80, you have about 80 or 90% chance that you have a bilateral hearing loss. Now, the same holds for the vascular system. You see it goes hand in hand, more or less, with the hearing loss. So over 60, 65, 10, 20, 30% of the people have a bilateral vascular loss, which is a major cause of falls and instability. Now, recent research showed that this bilateral vascular loss is very present also in children with sensory neural hearing loss. Here you can see Sharon Cushing's with a boy on the right, which is healthy, and a boy with an impaired vascular system, no labyrinthine function, and he cannot do challenging postural activities. Then he needs help, and it will never become normal. So this is a permanent problem. That has an incidence, as you can see, from 20 to 70% in the general literature. In the clinic of Sharon, about 35%. So we have bilateral loss already when you're born, it can be, and it can be with aging. Now, what are the possibilities? Of course, congenital, then we have aging, and in about 50% of the cases, we do not know where it comes from. A common cause is, of course, gentamicin, as you know, gentamicin intoxication. What are the complaints for a patient with a bilateral loss? Well, it's severe imbalance, that's number one. Chronic dizziness, so no vertigo, just feeling disoriented in about 50, 60%. Oscillopsia, instability, not able to recognize faces when they're walking, it is in 50%. And you'll see recurrent vertigo, hearing loss is less common. But imbalance is a warning. When you have an older person with imbalance, then you should realize that from research, recent research, measuring thresholds of the vascular system in elderly and other people, that vascular function may mediate in about 50% of the age effect on balance. So if you see a patient aged and imbalanced, you can be quite sure that in about 50% of the cases, there will be a severe bilateral vascular loss. Okay, now, why is it underdiagnosed? I already indicated. GPs are not aware of that this is happening, and they generally send the patient home with the message, it's normal when you get old. And they are not aware that there are therapies. So that's why a severe bilateral vascular loss is generally, that diagnosis is only made after 2 years and 7 or more consultations of different specialists. So that's a shame. So the key point now is that you realize yourself that we have with vasculopathy two entities. We have the vertigo attacks, very impressive, and that we need to treat. And we have the sensory function loss that we would like to treat as we do with visual loss and with hearing loss. So that's why I started to develop balance belts and vestibular implants since 2003. So to have a same situation for the vestibular system as for the hearing system. In general, the therapy for this quite common bilateral vestibular loss is visual therapy that can help the patient to a certain level, but it will never be perfect. And there are a lot of people that keep on complaining, and they score their balance and mobility on the scale from 0 to 10. They give it a 3 or a 4 or a 5 maximum. So that is what they say, how bad it is. 0 means I cannot walk without help, and 10 means that's the situation as it was before I had this problem with my balance. So 3, 4 is very common for this group of people. Balance belt is one option, and the vestibular implant is another one, although that is still research. I will give you some update about this. Now, biofeedback, visual training, so moving and seeing yourself moving or giving vibrations can help and support rehabilitation. So we use that idea of fibrotactile stimulation by designing a balance belt which you wear around your waist with all kinds of tactors around it and a small sensor that detects where gravity is. So if you move a little bit forward, you get vibration in the front. When you move backwards, you have vibration on the back and on the side. So you feel vibrations around you correlated with the orientation relative to gravity. So now when you are starting to walk, then you feel this belt walking with you and giving you automatic information about your orientation. Like when you go in the night and you can't see anything, you put your hand alongside the wall. Tactic feedback, haptic feedback. So now if you pay attention to that all the time, it becomes very fatiguing. So controlling, like you do that in rehab. But here we use it continuously. So we say to the patient, don't pay attention, just use it, and you will experience that as a subconscious spatial orientation reference. Okay, now, does it work? This is about 15 years ago with one of the prototypes. On the left side, the balance belt is switched off, and on the right side, it's switched on. And you see a clear difference. The patient on the left, without an adequate belt, needs her hands all the time to balance. And despite all the rehab that she had, she is still unstable. Whereas in the right example, the situation is that the patient really can walk without too much movements of the hand and can move faster and more stable. Now, designing better and better belts, learning from all the pilots, we made a belt and we could do a study in a big population of people. And what we found is that when patients are wearing the belt continuously, so they're using it like a hearing aid, they improve from an average score of 4.2, that is their balance score, to a score of 7.8. And these were all patients with bilateral vestibular loss, a peripheral loss, no neurological abnormalities. Now, then we started to improve the belt to give continuous stimulation all around, so improving it, and start to use that in daily practice. And try to find out, at the long term, does it also help, yes or no? So, 74 patients and 56 patients said after 2 weeks of use, yes, this is something that helps me. So it's about 70–75%. And here you can see what happens at the longer term. So after 2 weeks, the other patients, 28 drops out, 21 drops out, and they say, no, we don't experience any benefit. So here you can see that at the long term, even after 2 years, people are wearing the belt continuously. So conclusion is that this balance belt helps to improve the score of their balance. In all kinds of other studies, it now turns out that it slowly migrates to 3.5 to 7, so doubling, the score. It works very good in patients with DVNA9 and in gentamicin intoxicated patients, but it's not successful in neurological balance disorders. So the selection has to be correct, and patients should be instructed not to pay attention to the vibration pattern. Okay, now the next step is the vestibular implant. So we developed together with our Geneva colleagues a vestibular implant, and we published 32 international papers about that, so you can easily find that. What is the principle? It was a modified cochlear implant to have easy commitment and support from the Medical Ethics Committee, where we added motion sensors that we connected together with the audio sensor into the processor. And then this implant is composed of a cochlear electrode and 3 electrodes going inside the ampulla. So that's how we can stimulate the system. In the beginning, the patient was still connected to the computer, and then with more and more development, we could minimize the technology, and now the patient can walk around. Now, this implant, what did we find? What are the results? I will tell you a little bit about the results and the background, and here's the patient sitting in the dark with all the crew around him or her to measure, I think, the precise functions. Meanwhile, we have implanted 21 patients. The first was in 2007, and we did the first human implantations in the world in 2012 with a 3-dimensional vestibular implant. Okay, let's have a look. Now we're going to stimulate the horizontal canal. And what you can see is a horizontal nystagmus. There we go. You see? Very nice. Now we're going to stimulate the superior canal. So, and what you will see is a vertical eye movement with a rotation, downbeat. And here you can see the posterior canal, and you see an upbeat and a rotatory component. So we can modulate the input to the whole labyrinth in 3 dimensions. And of course, the eye movement and the effect depends on how strong the current is. So we find out what is the acceptable window over which we can stimulate, and then we go on. The brain very fast learns how to deal with it. You can switch on and off the implant without any problem. Adaptation goes very fast after a few times. Now here you can see an example of the rotary chair. So the blue line is the rotary chair moving with higher frequencies going to the right. There is the red line, there is hardly any vestibular occult reflex. Now, if we switch the vestibular implant on, we see that with increasing frequency, there is more and more eye movement, so we can restore the vestibular occult reflex. We confirmed that also with head impulse tests. So you can just look at the literature, you can find a huge amount of data about this. Crucial is, can you also restore dynamic visual acuity? So the patient is walking and has a blurred vision, as you can see here. So what we do, we measure the dynamic visual acuity. We do that by first measuring the static visual acuity when the patient stands still. Then the patient starts to walk on a treadmill, and of course, vision reduces, and we measure how much. Now, in patients with a bilateral vestibular loss, their static visual acuity is normalized to 1. And then they start to walk, the visual acuity goes down by about 0.3. When we switch the vestibular implant on, it's almost restored to normal. And in the placebo mode, there's hardly any effect. So we could prove that we can restore dynamic visual acuity. We restore also gait, as you can see here. With the vestibular implant activated, the patient walks more easy. This is still connected with the computer, and this is the patient that we operated a few months ago and is now walking around with the vestibular implant, able to rotate the head, see things, have a good dynamic visual acuity. So it's easier to walk, wanted to run, the walking task and easier to perform, and when I walk, I can read signs again. Now, important is that you know we did 21 implantations and there was zero complication. We didn't have any hearing loss, but that was because we were selecting only patients selected for a cochlear implant. But meanwhile, we also developed the technique, the surgical technique, to preserve hearing. So vestibular implants are coming on both for patients that are deaf and patients with normal hearing function. Now, it's very clinical useful. We're developing and going on, and I'm pretty optimistic that in a few years, the vestibular implant will be available like the cochlear implant. Now, what are my take-home messages? Acute loss, immediate rehab, and beta-estina. Do that for about three months to support central compensation. Don't expect beta-estina to take away the vertigo. It works on the compensation. Don't sedate patient as it impairs central compensation. So explain that to the patient that it's not good to reduce the vertigo simply for a long time, because then it takes away the trigger for the compensation. Bilateral vestibular loss is very common in elderly, especially also very common after gentamicin treatments, when you're not taking care of the sensitivity of the vestibular system for gentamicin. Vestibular function may mediate in about 50% of the effect of balance in the elderly. And the balance belt is effective in restoring quality of life in bilateral vestibular loss patients. We have now quite a number of patients walking around with the balance belt continuously like a hearing aid. And the vestibular implant improves vestibular ocular reflex, dynamic visual acuity, posture, and gait. And there are more clinics in the world working on the vestibular implant a lot. Thank you much for your attention.
Sure. I remember you shown us the demo of balance belt during the workshop in Bangkok 4 years ago.
Yeah.
But unfortunately, I don't have time to try it. And so for whom who would like to raise a question for the online participant, you can just type on the chat box on the right side of your computer. So now I would like to invite the second speaker, Professor Jenny Bashiruddin. As we already had known that Professor Jenny is audiovestibular lecturer in the ENT department, Indonesia University, and she also the head of Indonesian Otorhinolaryngological Society. Prof. Jenny is going to present her lecture entitled Combining Vestibular Maneuver and Pharmaceutical Therapy, Patient Perspective. May I now pass the time to Professor Jenny to present the lecture.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Prof. Kingma. Terima kasih moderator Dr. Faisa. So it is my pleasure to present this vestibular together with you, Prof. Kingma. So as the committee asked me to give the my sharing about the combining vestibular maneuver and pharmaceutical therapy, patient perspective. So vestibular system interact with many other parts of the nervous system, as we know the physiology. The symptom may also be experienced as problem with vision, muscle, thinking, and memory. We know that maintaining balance is depending on input from a number of sources, which is inner ear, which is usually more than 50%. Eye pressure receptor, muscle and joint for the sensory receptor. And then all this organic combined in the central nervous system, which will be produce the control eye movement and postural control eye muscle, and we produce our balance. So talking about the vertigo, we divide into peripheral and central, which is the peripheral involving structures not part of the central nervous system, and most frequently the inner ear. And the central, we usually involving structure in the central nervous system, such as cerebrum, cerebellum, and brainstem. And don't forget the physiology of equilibrium, also organized by the semicircular canal, which is usually influence our head position, which we know that this is the lateral left anterior semicircular canal. It is together with the right posterior semicircular canal and the right anterior semicircular canal together with the left posterior semicircular canal and the left horizontal semicircular canal and right horizontal semicircular canal. So we should know about this anatomy, because we will see what is happened in the benign paroxysmal positional vertigo, which side of the semicircular canal is involved. So the sign and symptom, we know that the vertigo, episodic autonomic symptom, hearing loss, and triggered by the head motion. And we note that if the sign and symptom very hard, then the quality of life will be decreased. And also the palpitation, cold sweat, nausea and vomitus, and anxiety to fear. So the most frequently reported symptom of vestibular disorder are dizziness, unsteadiness or imbalance when walking, vertigo and nausea, and this symptom may be quite mild, lasting minutes, or quite severe, resulting in total disability. In addition, may suffer headache and muscular ache in the neck and back, increased sensitivity to noise and bright light, fatigue and loss of stamina, and inability to concentrate. May be accompanied by irritability, loss of self-esteem, and or depression. So we should also differentiate it between central and peripheral. Usually the central is gradual onset, but the peripheral is sudden onset. Central is mild, peripheral is severe, triggered. The central it's not triggered by head movement, but the peripheral usually triggered by head motion. So autonomic involvement in central, but in peripheral sometimes it's very dominant. Hearing loss and tinnitus, there is a no, and the peripheral sometimes have the hearing loss and tinnitus. And in central there is neurologic deficit, and in peripheral usually there is no neurologic deficit. So what should we do? We should examine the patient from the anamnesis or history of the problem. It's very important, which is we should ask about the onset, intensity, duration, change the position, episodic or continue, other disease, and ototoxic drug and trauma. So the cerebellum examination, we also do the pass pointing test or finger nose test, and we do the proprioceptive examination such as Romberg and stepping test. And we do the neurologic examination such as the general ENT, otoscopy, audiometry, posturography, or caloric nystagmus if we have the equipment, and we do the Hall-Pike maneuver, positional nystagmus, and ENG if we need. Yeah. So we do the dysdiadokinesis. Everybody already know this kind of test, finger to nose test, and the pass pointing test for differentiated between central and peripheral. And then we do the gun sensory organization performance, like this is the picture. If normal, if we can do with eyes open, eyes closed, and then the what do we call it, the Sharp-Romberg test, which is we have the eyes and also closed, and we do the stepping test. If there is an abnormal, then when we do the closed Romberg with eyes closed, there is abnormal of the result, which usually have a false. And then if there is all normal, but the false is in when we do the Sharp-Romberg test, or we give the rubber and eyes closed, and then it's false. So it means that the organ which is work, it's only the vestibular, and only the vestibular, which is the eyes and the proprioceptive we sorry. Oh, okay. Sorry. Because, yeah, sorry for the inconvenience of the slide. Thank you, Dr. Faisa, to remind me to do the slide. So this is the finger nose test again. Pass pointing test. This is gun sensory procedure of performance test. And then don't forget to do the vestibulo oculoreflex, which is we know that to maintain or stabilize head through proprioceptor and neck muscle, head motion response were stimulated by otolith organ such as utricular and suckle and semicircular canal. So we do the posturography if needed. Yeah. So the posturography increase postural sway, and then also this is for the knee exercise and ankle exercise, and then more difficult we can do this exercise. So where this system persists, some patient can be cured completely. In other persistent cases, the symptom can only be controlled and not eliminated entirely. Treatment may consist of drug, diets, and physical therapy. So as summary, diagnosis of vertigo can be made clinically through identifying the sign and symptom and performing several physical examinations. Through sign and symptom, vertigo can be classified into central and peripheral. The peripheral vertigo is caused by disturbance of vestibular apparatus in the semicircular canal. The most common is BPPV, which is triggered by head motion. Beside the ear, vestibular system receive input such as visual, cutaneous, proprioceptive, and cerebral input to maintain equilibrium. To provide an accurate management of vertigo, it is important to identify the source of lesion through several tests. So technical modification and examination should be considered for limitation patient and movement, especially in elderly, and balance problems should be managed properly, cause of increasing the morbidity and mortality, and need proper teamwork from several departments and family to improve the quality of life. Thank you very much, and sorry for the inconvenience. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Eni, for very interesting lecture. Now we come to question and answer session. I don't see question on the chat at the moment from the online participants. Now I would like to give opportunity for raise a question from the floor. Is there any?
Assalamualaikum warahmatullahi wabarakatuh. Goedemorgen, Prof. Herman Kingma. Good morning. Yeah, my name is Rosa Valerina, M.D. I'm from Surabaya, Indonesia. Before my question is a very interesting presentation, and I've been there in M.Sc vestibular laboratory with Herman for about 2 months from August until September this year. It's very interesting, and I'm very amazed with the equipments of the vestibular laboratory. And my questions is for Prof. Herman Kingma. First, I have 3 questions, Prof. First, yes. Is the scan, like MRI, is it included in the protocol for screening in vestibular disorder, or just we can do the hint to exclude the central vestibular disorder? I think that's my number 1 question.
Yeah.
Number
first
2.
Answer it. If no, maybe I answer first.
Yeah. Yeah, please.
No, the MRI is not standard in the protocol. I think the first is always the hints, and if the hints is showing in the direction of a central disorder, of course, then we do an MRI. Yes.
Yeah. So if necessary, Prof. Yeah. Okay. Let me continue my second question. The vestibular implant is very interesting. I've seen once the operation with Herman in the operating theater. I would like to ask, in a unilateral vestibulopathy, we need it or not, or this is the indication for the vestibular implant or not, and how about the outcome of the operation regarding the other side is still normal?
Yeah. Until now, we only did surgery on patients that had a severe bilateral hearing loss, which was necessary to support with a cochlear implant, and they got a combination then, the cochlear vestibular implant. So we have no experience with unilateral deficits, but you can compare it basically with hearing loss. Normally when patients still have one ear that hears normal, then I think you don't consider to do a cochlear implant. Although things are slowly changing now, it becomes more. But in general, no, that's not the first thing you think about. And I think the same will happen for vestibular loss. If you have a unilateral lesion, then most likely we will not implant them initially in the first years for sure, because the handicap that they have, the impairment, is much less than that of a patient with a bilateral vestibular loss.
Yeah, nice. Thank you. Let me continue my third question, Prof. What's your suggestions for the case of vestibular migraine? As we know, many patients suffer from this. It's just a rehabilitation or maybe any other tips?
I think if you go into the research, then there are no very specific different rules that and medications that we use for vestibular migraine compared to migraine. So advices regarding life, not to eat certain substances, and the normal, let's say, medication that you also use in the migraine, so paracetamol and then the triptanes when it's more complicated, etc. So there's not a big difference. The issue is, and it's very good that you asked the question, is that there's quite a lot of overlap in symptoms between Meniere and migraine, and it's very difficult sometimes to distinguish in a patient whether it is migraine or vestibular migraine or Meniere. Because migraine patients have a bigger chance to have also the hearing deficits, and Meniere patients have a bigger chance to have also headaches. This overlap is a whole scala. So you have also what we call an overlap syndrome, where patients have components of both disorders. And then you are in trouble. So it is generally what we do, very pragmatic. First, try to treat one entity, and if that is not sufficient, we combine it with the treatment of the other as well.
Thank you so much, Prof. Herman Kingma. It's very nice. May I have a question for Prof. Jenny? Dr. Faisa?
Yes, please.
Yeah.
Still have time.
Good morning, Prof. Jenny. Yeah, I would like to ask, in one patient, if we found like 2 types of BPPV, like maybe from our examination, we've got like, okay, this is with the posterior canal type of PPPV and the anterior canal of PPPV. What should we do for the rehabilitation?
Yeah, thank you for the question. May I answer in bahasa ya? So you can excuse me, Prof. Kingma, I will answer in bahasa.
Yes, it's okay, it's okay.
Yeah. Jadi kalau ada kita dapatkan dua BPPV, berarti ada dua kanal yang terlibat. Pertama posterior. Ya. Jadi pertama kali ketika kita melakukan Hall-Pack manuver, ya, tentu kita lihat ya, misalnya kita lakukan Hall-Pack manuver kanan ya, kita kanan, kita balikkan ke terus kita lihat main nystagmus ya. Nah itu kita langsung lakukan reposisi kanal. And then kalau dia udah enak berarti stop. Tapi kalau dia belum enak berarti kita harus continue kan. Melakukan ketika dia ini nggak ada. Terus kita balikkan ke depan. Terus ternyata ada. Berarti kan kanal anterior yang ada. Sehingga kita bisa lakukan reposisi kanal untuk yang kanal anterior. Sehingga kita harus lakukan satu persatu karena kita ingat tadi ya gambaran dari kanalis semisirkularis yang anterior kanan berpasangan dengan kiri, anterior kiri berpasangan dengan posterior kanan. Sehingga ketika kita melakukan Hall-Pack manuver satu persatu kita bisa bereskan kalau dia belum baik karena itu biasanya langsung ya begitu kita lakukan CRT maka dia akan langsung enak. Berarti sudah selesai tugas kita. Tapi kalau dia tidak enak, kita harus mencari kanal yang lain yang terlibat. Kira-kira begitu Dokter Rose.
Ya.
Terima kasih.
Terima kasih Prof Yeni. Dank u wel Prof Herman Kingma.
You're welcome.
I
Thank you.
think we still have one more question from the floor. Is there any? I think no more questions. So, dear colleagues, ladies and gentlemen, that we come to the end of the plenary session on vestibular today. Today's lecture are not only learning experience, but we were able to gain insight on issues surrounding vestibular evaluation and management. So I would like to thank and gratitude to Professor Kingma, who has really to stay awake in this early morning. I know you are not too used to do this, right? So we really appreciate that, Prof. Kingma. And
You're
also
welcome.
for Professor Jenny Bashiruddin to the excellent and enlightening presentation, as well as discussion on this issue revolving around vestibular sciences. So with that, ladies and gentlemen, hopefully this plenary lecture provided all of us gain knowledge and beneficial for everybody. And thank you for your active participation that we hope to see you again in the next event.
Thank you, Prof. Kingma.
Thank you, Prof. Kingma.
You're welcome.
Dr.
Thank
Faisa.
you.
Thank you.
It was an honor.
Thank you.
See you next time on the next event.
Next event. Thank you.
Yes.